I'm doing my site impact. You all know that I'm Jason Dubs. That's my title slide, so we'll move on to the information. My objectives for the site impact is going to be to give you a couple definitions. The first one's what a doctor of athletic training is, and then the second one is going to be what an advanced practitioner is. And then we're going to move on to talk about some my pre-practice, my pre-DAT practice versus being in the DAT and after. And we're going to talk about professional application of the things that I've learned, and we're also going to talk about some patient-rated outcomes, and then we're going to talk about a little bit about my data that I've collected in patient-rated outcomes. And then we're going to have where I'm going to go from here, what my plan is, and then also we'll have some time for some questions hopefully at the end. So as I stated, I'm going to read this to you just because this comes straight off of Idaho's information that they sent us of what is a DAT. I put who is a DAT because it's a person. So DAT clinician has the skill set to work in multiple paradigms and combine various rehabilitative theories to produce meaningful and effective patient-centered care. Additionally, this purposeful clinical practice produces practice-based evidence that can be utilized to inform future practice and create future research questions for basic scientists. Ultimately, this clinician is empowered to effectively evaluate, recognize, and rehabilitate various acute and chronic musculoskeletal dysfunction and pain at an expert level. The combination of advanced clinical skill, a priori clinical practice, and research training prepares the DAT clinician to be an integral part of a translational research team that changes clinical practice to improve patient outcomes and create foundational knowledge for evidence-based practice. So, to nutshell all that, I put a couple things in bold because I think these are the main points of who a DAT actually is. So, purposeful clinical practice. Athletic trainers have purposeful clinical practice, but as far as the DAT, it's more about using your outcomes, your information, reflecting on that, and having purpose-driven treatments other than if I find this is injured and I've looked into the research, just this is what I think will happen. It's actually a lot about reflecting on your own information with that patient, but also with all the patients to see where you have strengths and weaknesses and what works for you and doesn't work for you. Utilize to inform future practice and create future research. So part of that I just went over. The first part, utilize to inform your own future practice, but also future research to help others in a more clinically based setting, because a lot of research right now that we use, if you go on and look up EVPs, a lot of it is in a very controlled setting. They try to control everything. They control, like, we want everybody to eat the very same thing. We want everybody to sleep the same amount of hours, or we want them all to do the exact same thing. But if you go out on a soccer field, for example, and you have people kicking, all their form is different, right? So then why do you bring them into a clinical research situation and you make sure they all kick exactly the same so that nothing's different? Or that's just one example, maybe it's good, maybe it's bad. But controlling everything makes it harder for us to apply because we're not applying it to exact settings as they're using in research. Integral part of the team for changes in clinical practice to improve patient outcome and create foundational knowledge for evidence-based practice. I just went over all that as well on my last point, so I'm gonna move on. What is an advanced practitioner? So some of this is just directly out of there, but it's basically a healthcare professional who is empowered to effectively evaluate, recognize, and rehabilitate various acute and chronic muscular dysfunction and pain at an expert level. But the key here is focus on specialization in certain areas. So some of our professors at the University of Idaho believe that other professions, they have specializations. Doctors, PTs, they have specialized areas that they perform in, ankle, knee, etc., right? So why could athletic training not have the same thing? Now that doesn't mean we become an expert at knee rehabilitation, knee treatment, and just only do that, but it's something that you focus on for improving your practice. Your focus on, I'm gonna get really good with hip stuff and continue on in that way. Using expert knowledge and outcomes to improve future and clinical practice and self and profession. I've gone through that a little bit already also, but it's not only about specializing and focusing where you're going to get better, but it's also using that knowledge to then do research and help the profession and help future people coming into the profession. And then scholarship and reflection are some of the ideas that I've talked about a little bit already, especially in my previous slide. But scholarship is obviously just getting the research, doing your research, maybe even patient-rated outcomes are a little bit in that because that's part of doing your research. And reflection is a big key for looking back at just interactions even. So right now we have that Heather's my AC, so we have conversations about what I've been doing in my DAT practice here. But then the big thing is after that, going back on that and reflecting, maybe writing it down like journaling or whatever you like to do, whatever helps you, to figure out what I got out of that conversation. And as I've spoken with a few of you, I like to talk, especially Mitch, I always tell you how I like to really get the information out of somebody, and that's why sometimes I'm argumentative, because I want to get the information out. One of those reasons is because I like to go back then with your information and my information and see if I agree with you, see if your points make me change my opinion, which almost always, there's some influence in every conversation I have almost that I go back and look at. Sometimes, as all people do, I just move on and I'm like, whatever, I was right, he was wrong, or I was like, well, he was probably right. I just kept arguing just to be difficult, who knows, but sometimes, a lot of times I try to go back and look at that. I don't always write it down, but I like to go back and look into that and see where you were right and where I was wrong and where we're in the middle and just kind of put all that stuff together. So reflection is the biggest part for me. I think it's a huge part for our program at University of Idaho, but it's definitely my biggest one in being an advanced practitioner and being a DAT and being a professional. That's all a big part of what I try to do is always reflect on whether it's my outcomes, whether it's my patients, whether it's conversations with coworkers, all that stuff. And it usually helps me become better. 80% of people believe they're above average. This is something that my professor said, and that's not an exact correct percent, he just made that up, but he says it feels true, so it might be true. And I agree with him, it's just really stuck with me actually. Because in athletic training, when I was coming up, there's one preceptor that really loves the supple leopard, right? And he's like, mobility, it's all about mobility, it's all about mobility. Then you need another preceptor, right? And you're like, okay, we've been reading the supple leopard book, I'm gonna try to start some of this stuff, and that preceptor says, that stuff doesn't work. You don't want a person to be over mobile, because then it's gonna hurt their shoulders and all this stuff, right? So you have to decide for yourself which one's better. But so do we just decide for ourselves, or the reason this slide begins the patient rated outcome measures is, can we actually look at our data and decide which one's better? Rather than us just saying, I really like mobility, I really like Supple Leopard, it's a great book. Kelly Starrett, I met him once when I was 10, and he was a great dude, and so now I'm gonna use that all the time, right? Is that your reason for using it? Maybe, maybe not, and if you know that it works for you and you feel that it works for you, that's fine. But something else we can do is collect patient-rated outcomes and see if it's working as well as we think. Because if we think we're getting somebody better all the time and they go back, that's fine, and they come back and see us next year and you're like, oh, I got them better again. Was this all part of one thing? Is this part of a different thing? We don't know, but patient-rated outcomes are used. All of us, I believe, collect an NRS, at least in our head, you know what's your pain level today, and we put it in our sportswear a lot of times. DPAS is a disability, and then PSFS is a functional. These are the three main ones that we collect at Idaho. They're doing a bigger overall research study where we actually do changes of pain for them. So we see between pre and post first visit, and then a second visit, or we do a first visit, second visit, third visit, and we put that into a Qualtrics system, and they're collecting all that and just trying to see how DAT students do. But they feel that they're the most important ones as well, because you're finding a pain, you're finding a disability, and you're finding a functional way to test them every time you see them. The other ones are also functional, but they're more specific. DASH is shoulder, arm, shoulder, hand. Some of these you, I'm sure, know. LESS is lower extremity functional scale. GROC is a global rating of outcome change. It's more like an NRS, but it's more how much do you think you've improved or not improved. So it starts out at 0, is just nothing's changed, and then you either go negative for I feel like I've gotten worse, or positive for like I feel like I've gotten better, and there are different words assigned to that. And then there's some back, another functional breathing, another back, anxiety, another upper extremity. Oh, sorry. I'm gonna stay here, just going to find. You probably can't see these numbers very well, but I'm just gonna point out some general observations I made here. So this is just like the mean. So for spring, this is their mean weight bearing, first visit, second visit, third visit. And then this is their percent of change from first to second, and then first to third. As you can see, there's wholly in here, especially in the spring 18, my first one in here. But I've gotten a little bit better in some of these parts, and some of them I've gotten a little bit worse. But real information that I'm getting out of this is you look at this stuff, and even if this is just percentage, like I said, and means of function, disability, and pain. So I can go back and look at this and see that I got worse from my first semester to my second, and then it started improving again a little bit. That's information, that's fine, but why did that happen? So I can have some ideas and say it could be this or this or this, but the key is then, after I reflect and to see all that information, see where I got better, see where I get worse, why did I get worse? You can go back and study actually, why did you get worse? Were these patients more comfortable with me because I'd worked with them for a year and a half, and then I get here and I just started working with the football team here, with there. And then it goes back up a little bit. Are they getting a little bit more comfortable with me? A way to figure that out would be go out and find a patient-rated outcome measure that has to do with comfort, or has to do, maybe I think that they're less adherent here, or they're less adherent at my last place. So you can find an adherence scale. Use that patient-rated outcome measure alongside with this, run some complicated statistics to decide whether you think that was a reason or not. Pre versus post DAT. EBP versus PBE. Another piece of information that we've gotten at the University of Idaho is about evidence-based practice. The 17 years is there because actually the knowledge gap between when they actually find something and when athletic training in general has put it into place is about 17 years. So back when they figured out, say, glute activation is related to patellofemoral pain, that was probably about 15 years ago. And a lot of people do that now, but I don't know, does everybody you know do it? Or is there people that you know that don't do that? I don't know. But I do know that there's things that you can probably think of right now that have taken a long time, or that you know that generally athletic trainers don't know yet, or they don't use it anyway, maybe it's the thing. Regional interdependence upgrade. Oh, I didn't move into my practice-based evidence, sorry. So the EBP versus PBE after the 17 years. So a way to get around that 17-year gap is to collect your own outcomes and decide what's working, what's not working. So evidence-based practice, right now we go and look at that clinically structured, as I said before, or in a lab structured research, and we take that and then apply it to our clinical setting where we're doing a lot of different stuff. We're seeing a lot of people that do not have controlled settings, but we're applying that research that people that a lot of times aren't even athletic trainers are using and finding, and they're saying, oh, so that's really good. And that's where you sometimes get a cross-country athlete telling you that that they read an article about how stretching before performance is bad for them. But then you look into the study that they read, and it's all sprinters and jumpers and things like that. So it's not really relatable for a cross-country person and a power sport athlete. Maybe it is, maybe it isn't. But one way to find out for sure is collect your outcomes. And then you can decide, okay, the stretching was really actually inhibiting their endurance sport, not just power sports, where they got from that article. Regional interdependence upgrade, that's a personal one for me, is that, you know, I've been looking at torso mobility for shoulder stuff before, you know, like the global looking at injuries. Obviously, when it just happens in the knee, you don't just look at the knee. A lot of people are starting to do that now. But then there might be other things also. For example, hamstring tightness. You can go look at their glutes and their back and all the other systems that you want to look at. But then also there's breathing, there's neurodynamics, there are things like that. There might be a root cause, could be energetic. So I would change to where I try to look at all of this rather than even just saying the knee and now I'm going to do glute activation. I'm also looking at breathing. I also want to see if their neural components are working what I think would be properly. Scholarship is another change. So in addition to just collecting these outcomes and reflecting on them, I also am starting to collect them for publishing research to hopefully help others as well if we find anything that I think is significant enough to write for. And also there's another saying from one of my professors that you have to know a white crow exists before you can find more than one white crow. And so that's why they use like case studies, case series. So through all your collecting of outcomes of your own, you can find one case that's really special. And like, that was really crazy. I did this, I've never done this before, and it worked on that person, they got better in 3 days. Well, if you've never seen that before, that's the white crow. Like, you finally found the right crow, so you know it's possible. And then you start digging into why that happened and seeing if you can replicate that and make it happen again. And possibly from one case study, you could get a case series of 4 or 5 people. And then after that, maybe you can start setting up a priori what the conditions were or what the athlete was and things like that, and then study it with it set up beforehand. And personal, I've had a lot of personal growth. You've all known me for about a year, so it's a little bit harder to see it, but I am improving. My communication skills are still a thing that I clearly lack, that I'm really still working on a lot, but I'm trying to use more of some energy and meditation type of stuff that we've learned, possibly get into some yoga at some point would probably help a lot too, but my thing is being really jacked up. So when Mitch asked earlier if I was a little bit nervous, I was pretty settled down and not as nervous until I got in here. But once I get in here, it's not so much nervous as it is like I'm really jacked up and my blood is flowing and my nerves are going. So that's something that I need to probably tap into a little bit more of the meditation and things like that, just to get myself in situations like this settled down, or before conversations, and just settle down a little bit. Applications for Purveya SNC, I'm going to take that out just because in general, but for our customer service surveys, a really good way that I think this could be integrated into Purveya, for example, is we have customer service surveys that are all given at the end of the season. If you work with somebody for the first 2 weeks of the season, or pre and into that season, and then 3 months later, or for hockey, 4 or 5 or 6 months later, they're filling out a survey, they probably don't recall as much. I tried to look up a study real quick last night and the night before to try to find, to back this up. So I'm pretty sure that one of my professors at Arkansas pointed this out, that people actually do report subjective information different months out, but maybe that's also obvious, I don't know. I think, like, if you think about it, they're not gonna remember as well. I know me personally, if I'm trying to report on pain from 6 months ago, it's not gonna go well, because I can't remember what I felt like last week sometimes. So, one thing to do would be take them customer surveys, maybe take some adherence, or even if you're just taking regular patient reported outcomes like our NRS, PSFS, DPAS that I showed earlier, then there's actually some statistics tests that you can run to compare those two seemingly very different pieces of data and see if they are actually getting better, because we do have that one question, do you feel you got better every visit? Well, if we're tracking every visit and we can see that they're getting better and they say no, then there's something to be discussed or looked into. So obviously we're not gonna go to them and say, hey, you've been lying to us. But some of us could feel a little bit better if we're affected more by those customer service surveys, and we're like, that person really said I wasn't doing very well, but here I can only see that I know I was doing really well. Because I'm more extrinsic. Some people are intrinsic where they can just say, I know I'm doing well, so that's fine. I would like to be able to see it and be like, okay, they said that, but like right here, it looks like they were doing okay. That's helpful to me. Another application for overall would be the paradigm sharing, which I know we discuss at times, and I don't still get into them deeply, but one of my intentions is to start sharing these things once I feel a little bit more comfortable with them, how to help you guys learn some of these too, things that you might want to use, and maybe you want to throw them all out, I don't know. Because you all do pretty well so far from what I've seen. That's not me judging you and saying you're doing a good enough job. I know you are. Promotion through research presentations. I really wanted to get out there at Purveya and do some research presentations, do more stuff like this in here maybe, or maybe get us all kind of doing some fun stuff like this. I think it'd be really good for our knowledge, especially as a group. Open patients to new and different ideas. Those are mostly the energetic type of thing that I really want to get more into once I get more comfortable with the manual therapies for some reason. I already discussed it a little bit with some of my athletes. I started telling them about meridians and about energy, and there's this thing called a chuck it bucket, you know, put all your fears and everything about that in this little bucket and you just chuck it, literally. But so I like to introduce some new things like that to the patients as well. And then provide the holistic treatment of mind and body, which I referenced multiple times already, so we'll just move right past that one. Where do I go from here? Continue research. That one's stated obviously there. Present research locally and nationally. So I just addressed that a little bit, but I'd also like to start and help start UW-GB symposium possibly, or even a Purveya one if they would be open to that. That'd be pretty cool to kind of rival Aurora, and just maybe get more research based even for Purveya specifically. Because I know most of us in here already look at research at least, and we try to keep up on everything. Whoopsie, that was unfortunate. I want to pursue some more energetic certifications based on what I've already learned. I want to pass on what I've learned, not only through the research and the presentations, but also hopefully if we ever become preceptors, if everybody's into that, I would love to be able to pass a little bit of different type of knowledge on to some of the future clinicians. And be at peace, that's the personal bit. I'd love to just be a lot better at being more peaceful, which I described earlier. I'm jacked up a lot, so I'd like to not be that way. Questions?
I have a question.
Should have provided questions. Yes.
What are your thoughts on athletic trainers specializing in a specific area? Well, you mentioned before on the advanced practitioner slide,
Yep.
that PTs are kind of really getting into specialization.
Yeah.
Athletic trainers that deal with multiple sports, different joints get affected.
Yeah.
Do you think specializing would be good?
I do, and so, as I mentioned, I don't think that we should just only do shoulders and then say, I'm just gonna do shoulders. But I think, for example, you work with baseball. A really good way for you to direct that, because I believe that's one of your favorite sports, would be to direct yourself, a lot of your training towards baseball stuff, towards shoulder stuff. like dig really deep into the anatomy as far as nerves go, as far as all the vascular system, muscles, how it works. Just like if you spent a year just focusing, well, not focusing, but your number one priority or whatever as far as research goes would be shoulder, doing research on shoulders, doing research on your baseball guys. When you look up other research articles, looking into shoulder stuff and becoming like a shoulder guy almost, like you can still work on all the other stuff through these same pathways. But then if one of us has like a question and I'm like, man, I've been working with a shoulder guy, I've been trying for like, 3 months, everything's just not going well, Evan, do you have any ideas? You'd be like, absolutely, I know exactly what to do with this guy because I've been specializing in his shoulders. And especially in a setting where we have 5 athletic trainers, there's probably 5 major body parts that we could focus on and we'd all be an expert. And that way, shoulder come to Evan, If we have a hip thing, go to Mitch because he does hip and low back or whatever, or just spine specifically, or knee or whatever, you know what I mean? So if we each focused on getting a lot better, good English, a lot better at one specific area, then we, as a group, could be a whole body expert almost, you know what I mean? Like the fingers that make the fist. That'd be awesome, I think. Anybody else with any questions? It's okay if you don't have any.